So we know that the progress in infertility management has improved in improving the success rate, lower the rate of multiple pregnancies, simplify therapies, and allow us with new therapies. I think they've done some mix up with the slides. And we've come to this conclusion after we go through different meta-analysis, randomized control trials, guidelines and protocols which are being provided by ASRM, ESHRE and RCOG. We're still climbing the ladder with new innovations so as to improve the clinical pregnancy rate per transfer, and I would divide my talk into these 10 different topics. Coming to advances in diagnosis, we know that 3D and 4D ultrasound, which are multiplanar display with volume and surface rendering, have helped us in improving diagnosis of several conditions like intrauterine adhesions, polyps, fibroids, congenital anomalies, and also helped us in determining the exact ovarian volume, antral follicular count, endometrial volume, and several adnexal pathologies which would help us in treating our patients. We also know that antral follicular count is a good predictor of hyper as well as hyporesponse, and at a cutoff value of more than 14, it has a sensitivity of 82% and specificity of 89% for predicting hyperresponse, whereas at a cutoff value of 10 or less, the sensitivity is not as much as with a cutoff value of less than 8 for predicting poor response. We also know that MRI is a superior technique in imaging the soft tissues and would be helpful in diagnosing adenomyosis, Mullerian abnormalities, adnexal lesions, and it has a sensitivity and specificity of 78 and 88% respectively. Dr. Nalini would be speaking in large on AMH, and I would just like to tell that it is again a very good predictor of hyper as well as hyporesponse, and hyperresponse is predicted at a cutoff value of 3.36 nanograms per ml with a sensitivity of 90% and specificity of 81%, whereas it predicts poor response at a cutoff value of 0.99 nanograms per ml, but it's best with at a cutoff value of 0.59 nanograms per ml. We also know that there is a evidence which links sperm DNA fragmentation to poor reproductive outcome, as it has an impact on the embryo as well as blastocyst development, pregnancy as well as pregnancy loss, and therefore in patients who have not conceived despite good counts and motility, we usually prefer doing a DNA fragmentation test, and if it is high, we need to treat them with antioxidants, and if the levels do not come down, it has been shown that it is better to do a TSA-ICSI because a sperm from the testicular tissue does not have high DNA fragmentation. Coming to advances in ovarian stimulation, we know that these advances have helped in simplifying the procedures, and today with the availability of choreofolitropin alpha, which is a depot preparation of FSH, and once given, its action will last for about 7 days, and if the criteria for administration of HCG is not reached, then we could probably add on recombinant FSH in the dose of 150 to 200 IU, and here we can see that there is no difference in the pregnancy rates between choreofolitropin alpha as well as Rekegon. We also have another product which is a combination of recombinant FSH and LH in the ratio of 2:1, and it is marketed as Pergoveris, and there were 2 studies conducted using this drug. One was by the Spanish group which used it for suboptimal patients who are young poor responders and older women, and they had a pregnancy rate of 25.9% per initiated cycle and a pregnancy rate of 32.2 per transfer. The German people also, apart from those, they also included those people who had a low basal LH level, and they had a pregnancy rate of 27.5%. We know that LH is required in patients who have LH deficiency, and it includes the WHO type 1, which Dr. Jayakrishnan has already told us in the morning, and also in those patients who are treated with agonist and antagonist. But it was shown in this meta-analysis that there was no significant difference in the live birth rate with addition of recombinant LH to FSH in patients treated with agonist and antagonist, and there was also no significant difference in the secondary outcomes mentioned out here. We know that the current stimulation protocols have high E2 levels and therefore can have effect on the maturing oocytes as well as chromosomal segregation, with increased complications like ovarian hyperstimulation syndrome, multiple pregnancies and prematurity, as well as financial and emotional stress. So we have simpler alternatives in ovarian stimulation in the form of natural cycles with or without medication. But we must know that we aim only at a single oocyte in a natural cycle, and therefore we do have lower pregnancy rates. And so came in the mild IVF or minimal stimulation protocols, wherein we aim at 2 to 7 oocytes, and here we combine the oral compounds with gonadotropins with antagonists and HCG for trigger, and we also support the luteal phase. They are of good use in patients who are young, good responders and PCOS, but it is important that we have optimal laboratory performance and we individualize the protocol, and this has resulted in less use of lesser gonadotropins. It is less expensive with lesser incidence of hyperstimulation and multiple pregnancies, and it almost has an equal pregnancy rate which is seen over here. Though the ongoing pregnancy rate in the first cycle is 8.3%, it's almost 20.8% after 3 cycles, whereas even when used in IUIs, we can see that the cumulative pregnancy rate after 3 cycles is 43%, but we can see there is a marked reduction in the multiple pregnancy rates. There was no evidence which showed that there was any difference when we use recombinant human chorionic gonadotropin as against the urinary, and therefore we could use either of them as long as the urinary gonadotropin is of good quality. We have heard a lot on use of GnRH agonists to trigger ovulation induction instead of HCG, and we know that there is a definite decrease in the incidence of ovarian hyperstimulation syndrome, though we have seen lower pregnancy rates with agonist trigger earlier. But when we modify the luteal phase cycles in these patients by administering HCG on the day of oocyte retrieval, the pregnancy rates have definitely improved. We also know that in vitro maturation is an important option in patients who have polycystic ovarian syndrome, as well as in those who want fertility preservation in patients who are going to undergo chemo or radiotherapy, and we do not have time in our hand to preserve the oocytes or embryos. But we must know that it has a disadvantage, that it has lower pregnancy rates and there is lack of standard clinical protocols, and we need to have complex ovarian retrieval as well as lab procedures, and the long-term safety data has not yet still been available. But over the years, it has definitely there is a definite improvement in the pregnancy rates, and it has completely reduced the risk of ovarian hyperstimulation syndrome, though few data have become available on its safety. Coming to monitoring ovulation induction cycles, the use of 3D and 4D automated ultrasound using the Sono AVC software has helped in individually identifying and quantifying the size of any hypoechoic region with the 3D data sets, providing an automatic stimulation of their absolute dimensions and volume, and therefore they can quantify unlimited number of volumes and therefore eliminate the possibility of measuring as seen over here. We can see that each follicle is identified and it adds a different color over here, and so it eliminates the possibility of measuring the same follicle more than once. Though it is quicker and more reliable, but its effect on the pregnancy rate is not yet been analyzed. We also know that Doppler studies which analyze the quantitative and qualitative assessment of the perifollicular blood flow helps in assessing the follicular competence, and it has been seen that follicles that have more than 75% of their surface perfused with an ovarian stromal PSV of more than 10 centimeters per second and RI of less than 0.4 to 0.48 contain oocytes of satisfactory quality. We know that today transvaginal follicular puncture under ultrasound control has completely replaced laparoscopic oocyte retrieval, and this has definitely brought down the morbidity. Coming to selecting the right sperm and oocyte, which is most essential for a successful IVF program, we know that IUI and IVF involve a natural selection of sperm, whereas for ICSI, either using ejaculate, testicular or epididymal sperm, we just look at the morphology and we inject those sperms, but these may or may not be normal. So came in the use of MC, which analyzes the morphological parameters like the sperm maturity and the DNA integrity, and use of PIXI, which assesses the biochemical parameters and gives us information on the cellular maturity, viability, and usually if we collect the sperms which are bound to the hyaluron, these sperms are usually euploid and they are devoid of persistent histones and apoptosis. The other method of selecting sperms is by using the birefringence of the sperm head, and those which have a good or strong intrinsic birefringence, they have a mature sperm nucleolus, acrosomal complex and tail. But what does the evidence say? Has use of these techniques improved the results of ICSI? And till now, there's no sufficient data to say that we should use these techniques in all patients undergoing ICSI. We also know that we could look at the oocyte by using the oocyte imaging system, and we can look at the presence, orientation and size of the meiotic spindle. But it is not without a disadvantage, because we have to expose the oocytes for a longer time and it has not been evaluated clinically to date. We know that culture system is the most important part of any ART program, and the characteristics of the culture area can influence the media flow properties and physical forces impacting the distribution of autocrine factors and influencing the mechanical forces applied to the developing embryo. In a static culture system, what happens is that it alters the microenvironment for the embryo culture by either impacting the embryo density, spacing or surface area points of contact. And a dynamic embryo culture system helps in removal of harmful byproducts, replenishing the substrates, disruption of the environmental gradients, physical stimulation and activation of the signaling pathways. Though today we are not allowed to use the co-culture systems, but it can help in vitro culture by secreting various molecular growth factors which stimulate the embryonic development, extract factors, impurities or reduce the nutrient levels in the media and metabolize the free oxygen radicals. And the most important part is then selecting the best embryo, and the technique what we use should not damage the embryo, should measure the changes rapidly, measure the changes consistently and accurately, and should also not be technically difficult. One of them is use of blastocyst cultures, which gives us the opportunity to select a better embryo with temporal synchronization of the embryo and endometrium at the time of embryo transfer. Though the pregnancy rates when we do a day 3 and day 5 transfer are not different per ovum pickup, but if you consider per embryo transfer, they are definitely higher in patients who undergo a blastocyst transfer. And this allows selection of a genetically competent embryo, and this will also help us in avoiding the inheritance of abnormal paternal genomes. So, assessment of morphology, though used to identify the best of the embryos, we know that though we transfer grade A embryos on day 3 of the cycle or even a hatching embryo on day 5 of the cycle, they might not be a pregnancy, and we know that this does not imply the embryo, the competency of the embryos. And so, we have different techniques now which have come, which include the genomics, the cytogenetics and the use of metabolomics and proteomics to assess the oocyte and embryo quality. And the most used today is the metabolomics, wherein we know that the embryonic secretome represents a dialogue between the developing embryo and its external environment, and each 24 hours developmental stage produces a distinctive secretome protein profile. These profiles then characterize the developmental stage of these embryos independently of the morphology, and therefore could be used to predict implantation as well as viability. In future, probably we could even have DNA fingerprinting and gene expressions which would help us in choosing the best embryo. We know that pre-implantation genetic screening does not improve the ongoing pregnancy rate or the live birth rate, but it increases the cost, anxiety as well as epigenetic risk. But pre-implantation genetic diagnosis is definitely of use, especially in patients who are of advanced maternal age, who have repeated implantation failures and could have autosomal or X-linked or structural aberrations of the chromosomes, or in patients who have recurrent idiopathic miscarriages, and we could use FISH either on the blastomer or on the polar body. We again know assisted hatching either using chemical, mechanical or laser does not improve pregnancy rates except in a small group of women, that is those women who are more than 38 years of age, who have elevated day 3 FSH levels, repeated IVF failures, thick zona at the time of embryo transfer, and those women who are undergoing frozen embryo transfer. And definitely we know that embryo transfer forms the most important part of any ERT program, apart from the embryo quality and the endometrial receptivity, which would define the pregnancy rate. And we know that ultrasound guided embryo transfer confirms the position of the tip of the embryo transfer catheter within the uterine cavity and the site of embryo deposition, avoiding contact with the fundus and also avoiding the endometrial indentation. A distended bladder may also help in changing the uterocervical angle and allowing a less traumatic and easy transfer. There was a paper published which said that if we deposit the embryos 15 to 20 millimeters from the fundus, this has significantly improved the implantation as well as the pregnancy rates when we compare it when we used to transfer the embryos about 10 millimeters below the fundus. And this is evident from the side that the pregnancy live birth rates are definitely higher in patients who undergo an embryo transfer under ultrasound guidance. Availability of coaxial transfer catheter systems and application of 3D and 4D ultrasound has not helped in improving the pregnancy rates, and if it is done, it happens at a higher price. We again know that single embryo transfer and more so an elective blastocyst transfer has definitely reduced the multiple pregnancy rates, reduced the perinatal morbidity and mortality, caused prematurity, maternal risk and also psychological effects. We know that today vitrification is better than slow freezing because vitrification involves ice-free solidification. It reduces the cryopreservation time and it definitely improves the quality of the embryos post-thaw. This again is a very important topic wherein we need to preserve fertility in cancer patients, and apart from sperms today, we are able to freeze even the testicular tissue, and therefore young boys who have not reached their puberty can use this method to preserve their fertility. In the females, apart from the embryos, we could freeze the oocytes, the ovarian tissue as well as the whole ovaries for further transplant once the patient has been treated, and vitrification gives us better results than slow freezing. Today, the incidence of surrogacy has increased to such an extent that it has been done even in unindicated cases, but it is basically indicated in patients who have a functional ovary and do not have a functional uterus or have repeated implantation failures, and it is associated with a lot of emotional, social, moral, ethical, religious and legal controversies. In short, I would just talk on human embryonic stem cell cultures, which have had a major breakthrough in treating several diseases and more so the nervous system problems and in organ transplants. Cloning, which is asexual reproduction, wherein a child's genes would come from a single body gene, and it involves either reproductive cloning, wherein we can create the entire child with that nucleus, or therapeutic cloning, wherein we just produce a clonal embryo and we can use this later on to generate stem cells. It could be beneficial in certain areas of assisted reproduction, human organ tissue and tissue transplantation in certain cancers, and for eradication of genetic disease. We also know we could have human genetic engineering, wherein we can change the genes in a living embryo by inserting the new gene into a vector, which is then inserted into the cells. And this could be either somatic, wherein we target a specific organ or a tissue of the body, and it does not affect the oocytes or the sperms. And this is currently undergoing several trials and with mixed results to date, but at some time probably we could use this technique in treating several diseases. The germline genetic engineering targets the genes in the oocytes, sperms, or very early embryos, and this alteration affects every cell in the body of the resultant individual and is passed in future generations. We know that germline engineering is banned in most of the countries except in USA, and with the help of germline engineering we could probably have a designer baby. And I would end my talk by saying that adaptation and personalization of fertility therapy may help to optimize efficacy and safety outcomes for an individual. And while no one can predict what the outcome of treatment is going to be for any infertile couple, but at the end of it, they should at least have the satisfaction of knowing that they have tried everything that was possible. And I thank you for a patient hearing. I'm sorry to be fast because I had to cover a lot of it.